And I'm going to take roll. While I do that, if you could look over the minutes so that we can get those approved as well. Okay. So, Tom.
Here.
Okay. Bob, I see you're here in my screen. I see Sue Ricky Smith is here. Susan Miller. Okay, Susan Miller is not here yet. Bonnie. Bonnie? Okay, Bill is not going to be with us today. Enrique? Okay, Michelle? Okay, Jeff and JJ are here. I do not believe we have a quorum.
Is that
Bonnie's
5?
here. Bonnie's here, so I think we do have 5 now. Hold on, so 1, 2, 3, 4, 5. Yeah, we have 6, so I think we're good to go. Okay. All right, and we'll continue monitoring who comes in, so we can correct the attendance. So, if you could look over the minutes for our last meeting, I'll entertain a motion when the time is correct.
Move to approve.
Okay, Bob has moved to approve, and do I have a second?
Second.
Okay, we had a tie. I think we're going to give it to Bonnie, or was that Sue? I couldn't tell which one. So, all those in favor of approving the minutes from April signify by saying aye.
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 Any nays? All right, we're off to a great start. So the next section is going to be a discussion and approval of the final rates for the 23-24 plan year. And Kirsten, I think you're going to be presenting this.
Yep, sorry, my mouse was lost on my screen and I could not unmute myself. So great start. Well, hi, everybody. It's great to see you again for our May board meeting and also to wrap up the renewal process. So this first series of presentations, we're really just going to walk through and remind ourselves of where we landed last month and what were some of the final decisions that we made and what are the rates looking like and the rate increases also by carrier and plan. And then John is going to go over the same thing for the life and disability lines of coverage and also give a couple informational updates. All right, so with that, and Rohan is running our Mercer deck. So this is Rohan's first board meeting. So thanks to him, and also we'll be patient with him as we get going. So Rohan will go ahead and move forward to the next slide, please. Great, and one more, thank you. Oh, and one more. We always put so many in the front here. Great, so over on the left-hand side, these will be familiar numbers to you. This is where we landed last month with the round 3 renewal increases. So the first 2 coverages shown are the medical coverages with MODA and Kaiser. Those landed at 3.74 and 5.8%, so both above the 3.4% target. However, we benefited from really favorable dental and vision increases that were all under 3.4%. Some of them even were a rate decrease. So when we take all the premiums combined for medical and dental and vision and all carriers, the overall renewal increase as of round 3 was 3.74%. So we knew we had a relatively small, compared to where we started, a relatively small delta to make up. And Rohan, if you'll go forward one slide, and then we'll kind of come back to this one at the end. So we talked about several different ways of getting there, and we had anything from package 0, which if we're looking at 2 levers, we have the rate stabilization reserve lever, and we also talked about benefit change lever and looked at some things like advanced imaging with Kaiser and specialty copays. So package 0 was the idea that, hey, let's spend RSR to buy down the full 3.34% delta. And then we looked at a couple variations from that moved part of that difference to benefit changes. All the way over on the right, we showed the scenario, hey, what if we funded the whole difference with benefit changes and saved the RSR for later? The board voted on package 0, which was paying for the 0.334% difference with RSR and not making any benefit changes this year. So Rohan, if you'll go back a slide, please, to the first one, let's look at where that landed. So Mercer worked with staff to allocate the $3.2 million in RSR between MODA and Kaiser. And really the primary driver here is thinking about affordability for the employees. So Kaiser received the majority of the RSR buy down, really trying to get that rate to an affordable level. MODA, we brought the rate down for MODA as well, just wanting to maintain a differential that was really in deference to the original differential and where the carriers had landed in round 3. So when we look at the dental and vision increases, which did not need to change, and the 2 medical increases, which both came down to 3.64% and 4.6% after the RSR subsidy, the overall combined renewal increase is 3.4%. And that's based on total premium for medical, dental, and vision for all carriers combined. And this year we didn't have to worry about taxes and fees. They didn't impact the renewal at all. Any questions before we go on? Okay, great. So Rohan, we'll go forward 2 slides now since we already touched on this next one. Great, so we just want to touch a little bit and kind of recap all of the different moving pieces with RSR. So all in all, we're spending about $4.7 million in RSR, but in different ways. We decided to invest in the program VERTA, which should result in a claim savings beginning in year 2. So this is not money that we would have to think about paying back next year, for example. Weight Watchers, we also voted to fund an additional year of Weight Watchers using RSR. That's about $1.4 million. How that flows into the renewal next year just depends on all of the work that we'll do together over the next year and with CIAO to understand OEBB's weight loss coverage options. And then $3.2 million of that $4.7 million was used for buy down. And as we talked about, we may need to pay that back next year out of RSR. That payback amount is not reflected in the balance of $31.2 million. Okay, Jeff.
See, I'm on. Okay. So my understanding, and I think the way the motion was passed is we are not borrowing money from the RSR. We are spending money from the RSR.
Yes. Yeah, if my language is confusing, then I apologize for that. We are spending from the RSR. There's no loan that's being created.
Yeah.
Yeah.
So I think on the next slide or when it also says something about loan, and so just wanted to make sure we were clear.
Yeah, this is what I mean by it. It's an important idea to talk about. And the amount is small enough this year, depending on what happens with experience. It may not come to pass, but it is an important idea to talk about, which is the underlying claims. So when the carrier calculates premium, they estimate claims for next year, and then they add on what they need for administrative fees, and they calculate a total premium. When we use RSR to buy down the premium, we're not reducing the actual costs of the plan. We're just making the premium what we're charging the entities. We're basically subsidizing that. And so when the subsidy goes away, you're left with the original full cost of the plan. Now, as I mentioned, if experience emerges favorably, maybe it will all be a wash, but in a normal year, we would expect next year's renewal to be higher by 0.34%. And that's what I was trying to illustrate when we talked about it in May. I think we also touched on it in the February or March meetings as well. This idea that when we offer a subsidy one year, when we take the subsidy away the next year, we have to make that up plus the increase for that year.
Okay, so
0.34% is obviously within the cushion that we have available for RSR, so we weren't that worried about it last month collectively.
so if I hear you right, if claims come in under projected, say $700,000, we actually will not have used the RSR, and from that standpoint, it's a paper loan. It could be used up to 645,000 on MOTA.
I don't know if I followed that example entirely, Jeff, but if we anchor to the idea that each year we are capped at a 3.4% increase. So next year, if the calculated renewal increase is at, let's say next year the renewal increase calculates at 2%, then we are fine. We could even renew at 3.4% and bake some savings.
Sure, okay.
Right, but if we're over 3.4%, part of that could have been related to this buy down, and we would have to tap into RSR to pay it back. Or to, again, subsidize the rate.
I think we have a meeting of the mind.
Yeah, okay.
Thank you.
Yeah. Good questions. It's technical but important. Rohan, next slide, please. Okay. There's a lot of interesting stuff on this slide. This is a slide that has historically been in the May approval decks. And I like this slide for a couple reasons. Let me orient us all to what we're looking at. So this is a 9-year history of previous renewal increases going back to 2014-15. Sometimes we look at renewal increases excluding taxes and fees, and we do that when we're comparing to 3.4% to see if we met the target, because the 3.4% standard allows us to exclude the impact of taxes and fees. In this setting, however, taxes and fees are included. And I think that's appropriate in this setting because what we're looking at is the impact on premium, what the entities are seeing. And the final premium rates include taxes and fees. So we can see going back to 2019-20, so for the last 4 years, the renewal increases have all been at or below 3.4%, often significantly lower. And even going back 9 years to the 2.9% increase from the 14-15 to 15-16 plan year, those are all very competitive renewal increases. The highest increase in that range was 4.3% from the 16-17 to 17-18 plan year. And we are gonna look at a little bit of benchmarking just to back up my comment that those are all really competitive increases when compared to the commercial market. I also wanted to highlight there are both blue bars and purple bars on this slide. So it's kind of interesting. The blue bar, those are projected increases, the projected average premium PEPM each year. So, you know, as Mercer went through with this renewal process, when we are projecting the renewal increase for the next plan year, we take an enrollment snapshot to use as the basis for all of our financial work, and the carriers do as well. So for the 23-24 renewal, back when we were working all the financials, we had a December of 2022 enrollment snapshot. And so that's looking at what employees are enrolled in which plans and how many employees in each of the plans. And that's what we use as the basis for all of our modeling. And from that enrollment snapshot, we can say, okay, well, if everybody stayed exactly in their same plan and got the increase that we approved this year, this is what we would project the overall PEPM, the per employee per month premium, to be next year. But in reality, it's not static like that, right? Because something really important happens in between the projection and the actual start of the plan year, which is the open enrollment process. So during open enrollment, employees find out what their updated employer contribution is going to be and how much they have available to spend on benefits. They also may be adding or dropping dependents or looking to switch plans either to something richer or leaner. So all the results of open enrollment will impact what actually happens, and that's the purple bar. So in the last couple of years, the purple and blue bars have been relatively stable. And that can happen if either the renewal increases are pretty low, because that's not disruptive to the members financially, or also if employer contribution is pretty stable, then you can also have stable enrollment. There were a couple years earlier on, 2015-16 and 2016-17, where the purple bar is lower than the light blue bar, and that indicates that employees either dropped dependents or they moved from a richer plan to a leaner plan. So let's look at a little bit of benchmarking next. Rohan, if you'll go forward for us, one slide. Great, so OEBB is a really unique group, but we wanted to illustrate the 3.4% renewal increase next to a couple of benchmarks. So 7.3% is first. That is from Mercer's National Survey of Employer-Sponsored Health Plans that we do each year. And this looks at employers in Oregon and Southwest Washington to see what kind of increase they're going to get. So these would be large self-funded employers in the commercial market. 8.2 and 11%, those are the national average increases for Kaiser. 8.2% is the national average increase for large groups in 2023, and 11% is for 2024. And then Mercer's internal trend projection guidelines for our fully insured business is recommending premium trends in the range of 5.5% to 11% for both PPO and HMO this year. A little bit of that, 1% to 2% of that, is due to the economic climate and what we're anticipating to be increase in medical provider wages and also the cost of medical supplies. Rohan, next slide, please. Great. All right, so OEBB, one of the great strengths of OEBB among many is that we offer a choice of plans for the entities to choose from when deciding what to offer to their employees. It adds a layer of complexity when it comes to budgeting and also making the connection between what we show here today and what an entity might see itself when after the results of open enrollment. So we just wanted to touch on that a little bit and maybe bring some transparency to the process so entities weren't surprised come 10/1/23. So as I touched on just a minute ago, an entity's actual renewal increase depends on many factors, including which plans are offered, the plans in which employees actually choose to enroll, how many employees enroll in benefits, and does that change during open enrollment, how many dependents are covered, and employer contribution amounts, which can influence an employee's behavior in deciding which plans to enroll in. So all of those things are going on in the background and will bear out during open enrollment. But again, looking at that December of 2022 snapshot, looking at where entities are today and the plans that they have selected, it looks like over 75% of entities would be expected to have their own combined renewal increase less than 3.4%. And again, just the caveat, open enrollment could and will change these results likely. But that was a big number. We wanted to highlight that. So we have two slides really that show the distribution of entities. So of the 252 entities that we have, this is looking at which plans they offer and how many employees are enrolled in each plan. And then we know how much each plan is increasing the next year. So we can calculate an expected increase for that entity, which says, hey, you know, if the enrollment in that entity stayed exactly as it is today, this is what that entity might be expected to see for a renewal increase on 10/1. And as we mentioned on the previous slide, over 75% of entities would be expected to have a renewal increase less than 3.4%. And that, yeah, thanks, Rohan. And we can see for that cohort, their average increase is 3.26%, and there were 193 entities. So by far the majority of entities in that lowest bucket. And then even for the remaining entities, we can see up top in the blue bar, those are the number of entities. And then the green bars show the average renewal increase for entities in that range. Oh, thanks, Karen. We appreciate the feedback. So this is saying that 21 entities would have an increase between 3.4 and 3.5%. 24 entities would see an increase between 3.5 and 3.6%. And then 10 entities might see 3.6 to 3.7, only 2 entities, 3.7 to 3.8, and only 1 entity each, 3.8 to 3.9. And then the next bucket is broader. It's 4 to 4.49, but the increase for that entity is 4.08. So really, no entity in this scenario, no entity would be expected to see a renewal increase greater than 4.08. And what's happening here behind the scenes is that each entity offers a different mix of Willamette Dental or Kaiser Dental or Moda Medical or Kaiser Medical, and the employees are all enrolled in their own mix for each entity. And so we see some of this variation is just really related to how much enrollment do we have in dental and vision, which is helping to lower the overall increase. And then how much enrollment do we have in Kaiser versus Moda? Because remember, Kaiser still has a little bit of a higher increase this year. On the next slide, we look at the same information, but now looking at the subscribers enrolled in those entities. So we saw that 77% of entities would be expected to have a renewal increase less than 3.4%. And those entities represent 51% of subscribers. And what's happening here is that we have a lot of smaller rural entities. So a larger number of entities in the rural areas that are outside of Kaiser's service area. So they're offering Moda as the medical choice. And Moda had the lower of the medical increases. And so that's why we're having the larger number of entities with the lower increase. And then in the I-5 corridor and the more major metro areas where we have Kaiser in the service area, those are the bigger school districts. So there are fewer of them, but they have more subscribers. Okay, great, thanks. Rohan, next slide, please. All right, so we just wanted to recap, basically, oh, Tom. Hi, Tom, you have a question.
Yeah, can you go back a slide? There's a number here that doesn't make sense where you say there's 26,000 subscribers in the one category to the right, but that's only one entity. I didn't know we had one entity that had 26,000 subscribers. So I'm confused by that one.
Yeah.
There's something wrong with the numbers.
Yeah, thanks, Tom, for pointing that out. I don't know how that happened. I agree with you. There's not one entity with 26,000 subscribers. So we'll work behind the scenes.
The other one's the same as well, 84,000. Yeah. That's not, that number's just wrong.
Yeah, they are wrong. While I keep going, we will look behind the scenes and sort that out so we can get back to you. Yeah, thank you so much for highlighting that. I apologize for that error.
No problem.
Great. So we just wanted to, again, I know we meet monthly, but sometimes it feels like years go by in between. We just wanted to touch base on the new goals that we all agreed on in the December retreat, and then how those played out in this renewal and the progress that we were able to make with the renewal decisions that were made this year towards achieving these goals. So I know probably I'm saying things we all kind of have memorized by this point, but one of our primary goals was this philosophy of shifting left, which is catching diseases earlier and preventing the progression of diseases, communication, educating our members about their available options, about how their benefits work, of course, meeting a 3.4% renewal increase cap, having a focus on quality and efficiency. This also encompassed the idea of always keeping the member at the forefront and making decisions that help manage costs, but while also helping the member in some way. And then legislative education and really forming partnerships with the legislature. The 4 to the left were within the scope of this renewal. And Rohan, on the next slide, we can look at some of the programs and decisions that were made and how those fit in. We talked about several Kaiser care delivery system innovation that leverage digital technology to expand access. Moda is adding Verda. Kaiser's expanding the number of colorectal cancer screening services that are covered at 100% in the preventive care tier. Kaiser's also offering naturopathic benefits to out-of-area dependents. For communication, Moda is going to expand translation services, and VSP is simplifying their benefit by moving from once every 12 months to once per plan year. To meet the 3.4% increase, we voted to discontinue the low-value WebMD. We voted on the Copay Max Plus program, which will play out in the next renewal. We used our available RSR to lower the renewal increase. For Kaiser and efficiency, or for quality and efficiency, we have Kaiser Permanente at Home program, lowering the insulin cost share cap to $35 and refreshing the short-term disability portfolio in light of paid leave Oregon. So a lot of progress this renewal, more to come next renewal as we all work together as well. Next slide, please. Great, so we'll just walk through these. The board approved the 3 Kaiser medical benefit changes: colorectal cancer screening, naturopathy for out-of-area dependents, lower insulin cost share cap. Rohan, thank you. For Moda, adding Virta for type 2 diabetes treatment and expanding translation services. For VSP, 1 program change for the benefit frequency now to be on a plan year, which will be more intuitive for members. For the additional coverages, we're going to renew Uprise EAP at their proposed rate, which was no rate change. WebMD, we voted to not renew. Weight Watchers, no rate change from the prior year. We're going to continue the program for at least an additional year, funded with RSR this year. Unum Long-Term Care, also no rate change. Unum's contract renews annually. And then we also implemented the Copay Max Plus program, which will reduce Moda's allowed pharmacy expenses by leveraging manufacturer coupons. And I believe that is the last. Oh yeah, and then maybe I'll pass this one off to John and he can touch on the LAD changes here.
Yeah, thank you. So this displays the changes to both the short-term disability plan offerings and the long-term disability plan offerings in light, to better align with paid leave Oregon. So that's what really this shows here. And then also an emphasis around the need to communicate to the OEBB membership so they understand the changes and have the information they need to make their elections at open enrollment.
Great, thanks, John. Okay, so the other purpose of this meeting is to approve the actual rate. So we are definitely not going to go through every single available rate table. They're here for reference, just so that they're handy for everybody. But we thought we would look at the composite premium rates for each of the carriers and coverages consistent with what's been looked at in prior years. So again, Moda medical renewal is 3.64%. So we're showing a PEPM increase here, but just to highlight, this is the rate change in the actual plan premium. We don't know how much the employees portion of the premium is going to change because that would depend on the entity contribution change, which we don't know. So this is just the rate change here. So for Moda Medical, the range is about $46 to $64 per subscriber per month, and we'll see this is consistent with Kaiser. Let's look at Moda Vision next, Rohan. Yeah, that one is good. Moda Vision, small decrease, anywhere from $1 to basically $1.50, depending on what plan you're in. And then Rohan will look at Delta Dental Composite next. Great, so for the dental, small increase for Moda, 1.26%. The numbers are, you'll see their numbers are just a tiny bit different over in the right-hand column. It has to do with rounding. The increase here ranges from about $1 to $2 per month. And then Rohan will go to Kaiser Permanente Medical Composite next. So the Kaiser Medical rate change ranges from $44 to about $73. Again, pretty consistent with that MOTA range. And then Rohan will go to Kaiser Dental next. Thank you. And the Kaiser Dental at its 3% decrease, employees will pay about $5 less, or entities will be charged about $5 less. And then Kaiser Vision, thank you. Tiny increase of about 50 cents a month for this plan. For Willamette Dental, the 0.85% premium increase equates to about $1 a month in rate change. And then for VSP, thank you, we have anywhere between like a $2 and a $5 decrease in rate for VSP Vision. And then we'll go through the life and disability coverages next. I'll have John take over for that. John, you might be on mute.
Yes, that pesky mute button. Yet again, so Rohan, we can just walk through these, so there's no need to go back and forth to the index page. So we'll go through these fairly quickly. Let me know if there are any questions. It's generally a good story. Basic life is no rate change, but dependent life is also no rate change. Next. Then the optional life, also no rate change, and the optional, so the optional spouse life and the optional child life is also no rate change. So accidental death and dismemberment, both the basic and optional rate, there are no rate changes here either. So another good outcome. And then we get to the short-term disability plans, and we'll just pause here just as a reminder. So with the implementation of Paid Leave Oregon, and again, entities do have a choice to either go with the state plan or offer a private alternative that they can apply to the state for a waiver for. And with the Paid Leave Oregon, there was a substantial trimming of the short-term disability benefits, just so that the things align. The other thing to note here is that there's roughly an 80% decrease in those continuing plans, and that's related to the fact that going forward, the Paid Leave Oregon or equivalent private plan will be the primary source of STD benefits or short-term benefits, and the OEBB plan will be secondary to that. And then, again, more just this is just more the short-term disability, the different types. There are the three different types. There's the voluntary, the mandatory employee paid, the mandatory employer paid. And then long-term disability. And again, this reflects those plans that are going to be offered for the 23-24 period, which have changed, and there are no rate change in those plans. And this is just the second set of those. Uprise, again, no rate change for the 23-24 period. And Unum is the same story. So this Unum is the long-term care, and both at no rate change. So let me just pause there and see if there are any questions. Okay. If there are no questions,
John,
oh, sure.
Before you jump into that one, I just wanted to answer Tom's question. Rohan, would you jump back to that slide that had the purple and blue graph and the 26,000 off to the right?
Gotcha.
Yes. Thank you. Great. So what happened is I just got overeager with the K key, and it is just 84 subscribers and 26 subscribers. There's no K attached to those.
Thank you.
Yes, I'm sorry for that. It's confusing.
Nope, no problem.
All right, I'll pass it back to John. Thank you.
Okay. And then we'll move on to some of the plan updates, the informational items for the board. Next slide. So again, I think everybody's aware that the public health emergency is coming to an end in a week. So that's on May 11th. And after that, there are certain changes that members will be seeing in their Kaiser and MODA plans. And so we'll just kind of walk through. So, and a lot of these changes were made to, promote the vaccination and the treatment of COVID during the pandemic. And again, those are being sunsetted at this point. So in terms of COVID vaccinations, members for the most part won't be seeing a huge difference because vaccinations are already covered as a preventive benefit in full. So for Kaiser members, no change. And for the MODA members, if you're seeking it out of network, you will see a change. During the pandemic, that was covered in full, but after in this post-public health emergency era, that will be covered with the applicable out-of-network cost share. And those, I think one of the things that people may or may not notice, depending on how many they used, were those over-the-counter tests that we were getting at no cost during the pandemic, up to 8 per month. Those will not be covered going forward. And then the rapid tests, so these are the PCR, the rapid tests administered or ordered by a physician, during the public health emergency, those were covered in full. And after the public health emergency, those will be covered at the applicable cost sharing level, which is, for lab, for those things, like any other condition. And then in terms of COVID treatment, they were covered in full during the pandemic, and then after the pandemic, they'll be, covered at the applicable plan cost sharing, really the same as any other benefit. And then for the telehealth, that will, that was one of those things that was really helpful to everybody to get through the pandemic and get some treatment. That will be it was covered in full during the pandemic and will be continue to be covered in full after the pandemic. For Kaiser and then for MODA, again, that was covered at the applicable plan cost sharing before and after. So again, members won't really see a change when it comes to the telehealth piece. And these are the MODA network changes. These are, plan-wide changes. We'll start with the out-of-area network. So beginning in October of last year, members who reside outside of the MODA service area have access to Aetna's national PPO network. And there was an exception for members who live in Alaska and Idaho, and they had access to the PHCS network. And then beginning, for the next plan year, members who live in Alaska and Idaho will have access to the First Health network rather than the PHCS network. And in terms of the impact, the analysis that we received from MODA indicates that 11 OEB members would be impacted, and MODA will work with these members to find them new providers in the First Health network. Out-of-area benefits. So currently, where an out-of-network provider is not available, claims for those out-of-area dependents are covered at in-network benefit level. So essentially, if network providers aren't available, you get covered at in-network benefits. So beginning with the next plan year on October 1, 2023, with the addition of that Aetna national PPO network, out-of-area dependents will need to access that Aetna PPO providers to receive the in-network benefit level. Again, this is not expected to impact too many people. And this is a pharmacy. The last one is a pharmacy network change. So currently, CVS is an out-of-network pharmacy, but members can submit claims for CVS and receive in-network levels of reimbursement at the contracted rate. But beginning with the next plan year, that exception will stop. And again, this is because if you have a narrower network for your pharmacies, you get better discounts. So that's really what's at play here. In terms of the impact, the disruption is expected to be limited to about 6 OEB members. And again, MODA will work with these members to help them find a network pharmacy. Any questions? Okay. So is the next piece with Aaron?
And I think the corollary question is this the point where we vote to approve the rates as presented?
Yes.
I move to approve rates as described over the last half an hour.
Okay. Tom makes the motion to approve the rates as presented. Do I have a second?
I second.
Jeff seconds. All those in favor of approving the rates as presented by our Mercer consultants signify by saying aye.
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 Any nays? Okay, that motion passes. Okay, so just to get us started back. Okay, so I think we can go ahead and continue on with this. I'm not exactly sure. Oh yeah, slide 75 through 77. Let's continue with the informational items. Yes.
Is Christy available to go through the health equity update then?
I am here. Ready?
Let's do it. Thank you.
Okay. Hello, everybody. I'll just do a quick introduction. My name is Christy Ewing, and I'm on our Mercer Well team. I have been supporting PEB and OEB from the Health Equity Work Group. And so today I'm just here and I'm excited to be able to share with you just a health equity update of what the group has been up to. And then just talk a little bit about some of the great work that you've all been doing and some initiatives I think that we have coming later this year. So let's move on to the next. And I guess actually too, before I dive in, I just wanted to share a little bit of my background. So I, previous to being at Mercer, was on the employer side in a large healthcare system here in Colorado. And then previous to that, spent about 20 years in Montana in a very rural healthcare system in well-being. And then also my background is in behavioral healthcare. I've done some direct patient care and then also some system level EAP work as well. So I'm excited to be here. So OEB is uniquely positioned really to support and address the unmet needs of so many of your employees. And so just wanted to show here, and this aligns so perfectly with some of the initiatives coming forward this year, just we know nationally that Black women do have a 2.9 times higher maternal mortality rate than white women. It's not as high in Oregon, but it is still higher. There is still a disparity there. And so one of the great ways to address this is through doula care, which I know, again, is coming in the future as a discussion and initiative point with OEB. Additionally, in other areas, just with mental health care with LGBTQ plus youth. And specifically in Oregon, there was just a recent information from the Trevor Project. And, you know, this is just, it's staggering the needs. Oh, is there a question? Okay. That just 45% of LGBTQ plus youth have considered seriously suicide in Oregon. And then also that 60% of the youth in Oregon who have wanted mental health care were not able to get it. Now, a lot of that is coming from fear of talking to somebody about their mental health concerns, and also fear of stigma or not being understood. But there is just a great need there, so an opportunity. And then the third bucket here is really just addressing rural Americans and the needs that are there. And just really that access point to high quality healthcare, and then also affordable healthcare services. And so some, you know, just different ways of looking at that, and considering, you know, for COEs, which I know, again, the Innovation Work Group is looking at, you know, that travel and lodging benefit, and just, you know, really looking at what the impact is to that rural population with centers of excellence. So it's just a great opportunity. So if we move to the next slide. This is just to show some benchmarking. And I know, OEBB, you are all working, and I think you're ahead of our benchmarking. So, but just wanted to share that health equity is something that, you know, other organizations are looking at. You know, 78% of employers, you know, are taking action of some sort towards health equity. There is some strategy work going on in that regards, and then 12% have yet to begin. Again, OEBB, I know you all as a board are really integrating health equity into, you know, your decisions, and when you're looking at programs and resources and benefits, that's already weaved into what you do. But a lot of this comes down to a couple key areas that, you know, understanding the problem. So collecting that real D and SOGI data at that aggregate, you know, having that aggregate reporting so that disparities can be identified. Because if we don't know they're there, obviously we can't do something to reduce the equity and equities. Respecting differences, you know, making sure coverages that, you know, meet the needs of your diverse employees and their families. Again, you have many programs and resources in place that are doing this. And then setting goals, you know, what are the goals that you have for your organization? And, you know, then looking at it on an annual or semi-annual basis to see how you're doing as far as reaching those goals. If we move on to the next slide, so just a couple things that we've been, you know, that over the past couple of years that I have been in place. You know, again, that data collection is really important, so that, you know, that those disparities can be identified. And so you'll see that as part of a lot. And I know in talking with Kirsten that there's, you know, some of the initiatives too is having some clinical targets that we're using that aggregate population data so that we can see for different populations if there are disparities, and then being able to put in programs or resources to support reducing those disparities. You know, making sure that there's programs that address identified health needs of different populations, whether that's making sure that they have culturally specific offerings, they're meeting different language, different, you know, and just all the different needs of populations. As we're talking about committees and ERGs and different groups, you know, making sure that there's representation from diverse populations. And then finally, the communication pieces take up number 4 and number 5 here. And so just making sure that, first of all communication represents diverse populations. and just represents who OEB is and who your population is when people, when communication is sent out. And then also making sure that you have a really wide different methods of communication. So making sure that folks with vision loss and hearing loss, and different languages are captured, and that people are able to access the information in order to make the best health decisions for themselves and know the programs and resources that are available. All right, on to the next slide. So one of the tools that was developed, and this was actually developed prior to me joining the health equity work group, but we do have a health equity screening tool. This tool has been used, basically it is used as a way for us to do a deeper dive when we are looking at programs, resources, or benefits to establish the health equity considerations. And so in this tool, you can see on the left-hand side here, there are different categories. And within each of these categories is a detailed set of different questions. And what our work group has found thus far, when we apply the screening tool to a program or resource, it's kind of like peeling back an onion. I will say the first kind of run through, most times we have another set of questions that we have to go back and either ask the vendor or the carrier, somebody, more questions so that we can really get a clear understanding of the program and of the different types of accessibilities and pieces of it that are part of the program to understand the health equity implications. Once we do that, we will then take everything that we've learned, and as a group, we discuss it, and then we also develop a health equities considerations document. This was been newly created in just the last couple months, and we shared it with the two PEB and there's two PEB and two OEB board members that do periodically join our health equity work group, and we shared this document because our goal is to be able to provide you, as all the board members, considerations for to take into account when you're making decisions. It's not meant to be at all a pass or fail or anything like that. It's just meant to be another piece of information or data that's taken into consideration when you're looking at different programs, resources, and benefits. And so we wanted to create something that was going to be easy for all of you to use, that would summarize the key points that you needed and give you the information that was needed. And so within that considerations document, what we've done is we have the impact to the member. Then we have highlighted kind of 3 considerations that could be health equity related. And then finally, there's the financial impact as well. Again, the tool has just been, it's been a tool that we've used really to start this conversation, and again, to kind of dive down into the health equity considerations. It is a dynamic tool. It is changing. We kind of have that on our annual plan to always make sure we're updating the tool to make sure it's meaningful and relevant, and is keeping up with the work that OEB is doing. Any questions on the tool? All right, so if we move to the next slide. So within our work group, we've been really busy. And so a couple things that we've done this year, we did update our health equity work group charter. I think it had been written maybe, I think it was 2 years ago. So it was due for a little refresh. So we've updated the language to make sure that it was aligned with the OHA equity language document, as well as just making sure that it is aligned with the current goals and objectives. We also have done some good initial work looking at GLP-1 treatments. Again, we ran the health equity screening tool. We used that to kind of start our conversation and our assessment. Then we also utilized our Mercer clinical team, Dr. Ian Chuang, to help give us that clinical perspective There are some historical inequities within GLP-1 treatments. And so it was super interesting to uncover. And so then we were able to then generate that considerations document that we provided to the PEB board at the last meeting, and can certainly make that available as well to the OEBB board. And we continue, and I know that looking at the future state for OEBB and with the development of the GLP-1 treatment coverage and guidelines, that initial deep dive of health equity considerations will come into play, and then more work with your guidance on what you would like to see us do there. Additionally, we have done some analysis of the diabetes prevention programs, just again using the screening tool, uncovering different questions that we had regarding access for language, hearing loss, vision loss, also cultural implications with different eating plans and what's recommended, and different ways for people maybe who don't have broadband or ways internet access to be able to participate in the program. We also looked at the MODA Behavioral Health Champions program. And then we've done an initial review of the Centers of Excellence for hip and knee replacement, and provided our Mercer team that's working, I think, with the IWG, just some of those beginning kind of health equity considerations. So as facilities are being looked at and the carriers discussions are happening, that when you're looking at quality, you can also bring into play some of those health equity considerations. Again, and a lot of those do apply to rural populations. So lastly, just some of our upcoming initiatives for OEBB is that, as I said before, the development of that GLP-1 treatment coverage and the guidelines discussion, evaluation of the doula coverage, and then as we look at the spectrum of cardiometabolic benefits, kind of looking at, what that spectrum looks like, where are there gaps, and then as we do a deeper dive into the different programs that are offered, also bringing in health equity considerations along with that conversation. And then those dental clinical targets by different race, ethnicity data points. Any questions? Yes. Is it Jonian?
JJ.
JJ. Okay. Thanks, JJ.
When we are looking at the numbers associated with groups that don't get the same level of care, are we looking at national regional averages, or are we looking at specific numbers within the OEBB or PEB group?
We're kind of doing both. I would say we look at national as kind of our benchmark, but then I think, yes, definitely we're trying to use the data that's being collected for OEBB and PEB specifically to identify those areas.
Because my concern, and this is something we've talked about a few times when we've had a lot of discussions about health equity, and it's an important subject, but most of the time it's just sort of fluffy. Here's the things that we believe are important, but what I haven't seen is here's some specific numbers. Here's the deficiencies that we have in our current system with our current populace, and here are the steps we've done to improve since our last update. I think that's far more valuable to us than just theoretical, this group is historically underserved in this category. Because to be honest, a lot of the equity issues deal with socioeconomics that are not necessarily reflective in the work group that is covered by PEB and OEBB.
Thanks, JJ. I appreciate that comment. And I think we are trying to utilize the real D and SOGI data that is being collected for the specific OEBB population to be able to provide you with that data so that decisions can be made on that, and not necessarily, again, as you said, in those kind of broader groups and just across the board.
Thank you.
Tom or Damien?
Tom,
Ali was first, I
and
think.
And Ali. Okay, Ali.
Oh, I was just gonna say what you just said, actually.
Okay.
I mean, it's a great comment, JJ, and we're getting closer and closer to having some really good, solid data. I think within the next year, we should have some good real D data to look at and start making some more targeted decisions and bringing the board a little bit more targeted, specific data. Go ahead, Tom.
Yeah, the only thing that I wanted to add was CIAO is trying wherever we can, particularly what we think are the most meaningful of the quality metrics. Example, blood pressure control and diabetes control, to have the data that's broken down by race, ethnicity. Also, if you notice that MODA is bolstering their availability and support of interpreter services. That's another, that whole second language. Now, the question is, how many people does OEBB serve that don't have English as their primary language? I think we saw some data maybe a year ago. Spanish was the primary language for 3% of our membership, and I think Russian was in the 0.9%. So the numbers are relatively low. I think it speaks to the demographics of Oregon to some degree, but and as you mentioned, socioeconomic status. People who we're covering are people in general middle class, and to get there, usually people need to have English, at least from the language standpoint. But it's just something that I think that it's been a gradual. I'm on the committee along with Sue Ricky Smith, and what we've seen over the last 2 years is a gradual increase in our exploration and request of our consultants and the requests of our carriers to do the things that we think are necessary. So, and as you see here, for the next year, the big things that are on CIAO's list for looking for 24-25 plan year for improvements are going to be looked at through the health equity lens. That's all I have to say.
Sue.
Yeah, thank you. The only other piece I bring into the room here, and JJ, I appreciate your comment. I think it reminds us all that context matters. So what you are experiencing in your area of Oregon versus those of us who are in the TriMet area, I would offer that as I look at the health equity considerations that are listed here, particularly in the Portland metro area, all of us are working with intention to diversify our workforces and are expanding our staff who are of color and would fit, probably one or more of those categories. And so I think, to your point, let's get down to the actual numbers that we are serving so that we can pay attention to that, but also be mindful that the needs, equity plays itself out differently depending on what part of Oregon that you're in and what population you are dealing with. And so I think as much specificity as we can get will help us refine the work here relative to who we are serving and how well we're serving them.
I do not see any more questions or comments. I'm sorry. So are we done with these slides? Health equity is the end of that presentation. Is that correct?
Yes, I believe that was the last one.
Okay, great. Sorry, that was my fault.
That's okay.
Okay,
No worries.
thank you so much.
Thank you.
We are going to move on. One more thing before our break. The benefits system replacement update, Matt.
There we go. Hello. Let me turn my camera on briefly and introduce myself. Hi, Matt Arness, project manager for the OEBB benefits project or benefits replacement project. And what I'd like to do is share with you an update on how we're doing with the project. Talk a little bit about why we're replacing the system, some of the challenge that we've had along the way, and then talk about a new go live date. So with that, let me share my screen. So as I'm sure this team is well aware of, but it bears repeating, the current management system is quite old, quite costly to support. I think it is over 20 years old in some cases, and there's been a lot of customization with that product. And so there's a great deal of upkeep that goes along with that in terms of keeping current with current technology and design. And then one of the things that I noticed coming into this project is also that we don't necessarily benefit from industry best practice collaboration in the technical space. And I'm sure in terms of the benefits provided, there's a ton of that. But in terms of the IT and the benefits management systems, generally it's a best practice if you're using a vendor that services many people across the industry, and then you're able to leverage some of those best learnings and best practices. And so that's one of the things that we're looking to do as a go forward policy, just for the state in general, but also with this project. And then also the member experience was behind the industry. And let me unpack those things just a little bit. So what does that mean? Currently, we have a manual financial module. So it's not within the benefits management system, but it's customized and designed through a series of databases that the team uses to run now. There aren't automated plan comparisons for the members. And so when you're in the system, generally it's a standard practice to be able to compare your plans, be able to see some different scenarios and understand those different cost benefits relationships right within the system as you're doing your open enrollment. Notifications, things like COBRA reminders, are not in our current system. And so those type of things we would want to be able to add to automate. And that's fairly standard with the offerings that are out there today.
Hey, Matt, I just want to let you know that you're actually not sharing your screen right now.
Are you kidding me? Is that because do I have to be granted permission?
There you go.
There
You're ready now.
It's working now? Okay.
Yeah.
All right. Well, thank you. Yeah, thank you. And sorry about that. Automated dependent care, just being able to verify eligibility within the system, some features like that. And then also plan management, things when plans change out, there's some automation you can do proactively in advance within at the state level, then also out to all the entities, so the school districts, the admins out in the districts who also are managing these plans. There's a lot of proactive work you can do in advance, generally in a program, in the benefits management systems that are available today that we don't have in our current system. So that just gives you a couple tangible issues that we have with the system and why it needed to be replaced. So along the way, oh, I went the wrong way. Hang on. Along the way, we've had a few delays, and so there's been some challenges. The first one actually happened before I joined the project a couple of years ago. Workday is a solution used for PAB, recently went live. There was some thought that there could be some synergies and some advantages to using Workday for a benefits management solution as well. And so about 6 months were spent investigating that as a possibility. As it turns out, there really isn't a space that they are expert in, and there were some other solutions that were better fits for what Oregon public employees and educators wanted. Many of you know or may be aware that the procurement process for IT is very extensive within the state. And so that is an extended process. It's about 18 months in general to go through a full procurement in IT right now. And that was also proved true of this case. And so that took a lot of time for us to get before we could select a vendor. Once we did select a vendor, we have somebody in TELUS Health, and they were formerly LifeWorks, that we think is a very good solution. They were a clear winner through the procurement process. So when we went through and did our round 1 and round 2 evaluations, they were consistently rated much higher than the number 2 option out there. But with that said, once we started going live, we did see that there was a couple of different approaches to the way we're used to running things in the state, which what I'd say is very rigorous compared to private sector, actually where I came from before. And so some of that was working with TELUS Health to have them understand what our expectations are for project management, and for that approach. And so we worked through those things with them. That took us about 3 months. The other things that we've had to look at is some risk mitigation. And obviously we want to avoid the open enrollment periods. So for our go live timing, but then also as we do this implementation, it's about a 22-month implementation. We have 3 different user acceptance testing periods that go on. And obviously that can be quite a challenge then if the team is working on open enrollment, which we want to serve our members first and foremost, if they're juggling a UAT and a testing period. So we've spent some extensive time making sure that the overall project implementation will avoid those periods. And if we do approach those periods, that we're looking at significant mitigation plans. As I mentioned, the financial data it is a fairly manual system right now. And so we're looking at going from manual financial management through a series of disparate databases to bring that into a financial module. And anytime you're making a change and a conversion of data like that, that increases the risks. It's inherently challenging to do. And so we want to make sure that we're giving enough time that we can fully analyze that and test that data in particular. And then finally, our transition and training. And I think this is one of the issues that I think if we're honest about ourselves as an IT organization across the state is we've had some challenging implementations, whether it's been recently Workday, Cover Oregon in the past, or even unemployment insurance during the pandemic. And so one of the things that we're very aware of as a project and sensitive to is the benefits programs that we offer people. This will be just like as payroll has been for Workday. These are highly sensitive areas, and we want to make sure that we get it right. And so focusing on these major risk areas, one of the things that we've done is gone back to TELUS Health, and we've shared with them our concern about wanting more time. And so we had a April 2024 go live date, and we went through and have gone through an extensive analysis of this over the past 3 months to say, is this enough time and can we mitigate the risks that we mentioned here? And we've come up with a new date of February 3rd, 2025. We feel like that gives us much more time to mitigate those risks, avoid those open enrollment periods, and make sure that we're delivering a benefits management system that will be rock solid when it goes live and able to serve the 2 benefits boards and the members within. The positive thing about this from a project management standpoint is that we're able to do this analysis. I won't dive into the financials of it, but we are well under our contingency fund. And so we had a vote with our executive steering committee on the new date. That vote passed to approve this, and we are within our budget as well. So we don't need to do a ask for that. Okay, that was pretty quick. Any questions from the board or otherwise?
Ali.
Thanks, Robert. Just like to offer a comment. We really have a solid team. Matt's done a really great job. You know, I often say the system is really the lifeblood of our programs, and we're really going to be delivering a lot of value to not just our members, but the organizations that we work with, the admins are really going to benefit in so many different ways. JJ brought up data earlier, and just being able to generate invoices and you know, reconciling 300,000+ people month to month. You know, this system will really deliver a lot of value. So we're really excited about it.
Well, great. Go ahead, Matt.
Well, I was just going to say at the back of this deck, and I've given it to Rose to distribute, there's also a 1-pager if you want to reference it later, or if you have people that are asking about the program, it'll be a nice handout summary level for everybody.
Well, thank you, Matt, for the update. Really appreciate it. We are going to actually, I need to see. It's probably a 10-minute break, I assume, right? Yes, let's go for a 10-minute break at right now. So back at 2:27, okay? Thanks, everyone.
Robert, I need to check out for about 45 minutes or so at 2:30. I have another meeting. I have to go approve something and be right back.
Okay, thanks for
It's
letting
going
us
to take
know.
me longer to drive over there than to vote, so.
Got it. Appreciate it. Okay, welcome back, everyone. Next up is a customer satisfaction survey results from Aaron and Jackie.
All right, thanks, Robert. Okay, so I'm Erin Ward, and I am with Mercer, and I've been working, partnering with Jackie and Cindy on the communications. So as part of that work, they asked us to, we reviewed the questions that were asked in the customer satisfaction survey, and then we also helped program it through SurveyMonkey. And then once the survey was finished, we have helped put together this report here that we're going to share with you today. So this survey was run last year. It was administered between November 13th and December 11th. And you can see here on the cover that we had 8,872 respondents, which is up about 1,000 people from the survey respondents in 2021. So Jackie, is there anything that you wanted to add before I go any further?
Nope, you take it away.
All right, fantastic. So we are going to, on today's call, we're going to cover an executive summary. We're going to go through the detailed questions and those responses, and then we're going to give you a highlight of some of the member comments. There is also an appendix, the two appendix in the deck. One has the detailed member demographic questions, and then also the detailed member comments, the coded comments. So we won't go through those in detail, but you have them there if you'd like to reference them later. So with that, we'll get into the executive summary. Thank you. As we analyzed the results from the survey, there were three things that really stuck out to us. One was satisfaction with the OEBB staff. Second was satisfaction with OEBB's website. And third was satisfaction with the communication. And related to the OEBB staff, 83% of people or respondents were satisfied with the overall service that they received from OEBB staff, with 85% finding staff to be helpful, 84% finding that staff was knowledgeable, and 82% finding that the staff relayed information correctly the first time. So those are all positive results. In terms of the website, it was consistent with what we found in 2021, but over 85% of members of respondents were satisfied with the content and the organization of the site. And then 92% indicated that they were satisfied with the benefits enrollment system, which is at the URL oebenroll.com. When we were asking about the education site, so that's that first stat, the 85%, that is the site you'd find if you went to oebinfo.com. And then related to satisfaction with communication, over 92% of respondents said they were satisfied with the communication, with 95% saying they're satisfied with the methods used, 90% indicating that email was their preferred communication method, and that 93% were satisfied with the frequency of communication. Now, I do also have, we have a column there for demographics, but if we go to the next slide, we have those demographics broken out into a little bit more detail. We're not going to go through the demographics in detail, so we're just showing you some high-level information here. But generally, the survey demographics, the survey respondent demographics were aligned with the general OEBB population. There were three discrepancies, and that was around member tenure, gender, and age. And let me walk you through those. So with member tenure, compared to OEBB's general population, members with long tenure participated in the survey at a higher rate than those that are short tenured compared to the general OEBB population. For gender, OEBB's population is predominantly female. However, a higher proportion of females responded to the survey compared to the general population. And then related to age, the percentage of respondents ages 45 to 64 was higher than OEBB's general population, and the percentage of younger people 18 to 44 was lower. Location, employee group, and employer were consistent with OEBB's general population. On the location side, the most common lived-in counties are the same. That was Marion, Multnomah, and Washington. For the employee group, the majority of OEBB members are licensed full-time and classified full-time employees, which aligned with survey respondents. And then on the employer side, the majority of OEB members work for school districts, which also aligned with the survey participants. So any questions about the demographics? Nope. All right, I'll keep going then. Okay, so then if we get into the questions, so the question here is, how would you rate your satisfaction with OEB staff in the following areas during the past 12 months? And you can see on the slide that we included both the responses for the 2022 survey, and then we also included the responses for the 2021 survey so that you could see the comparison. And when you're looking at the bars, the colors, blue indicates an excellent response, green indicates a good response, the maroon or red indicates a fair response, and then yellow indicates a poor response. So now this question had 6 different parts. You can see 3 here. So related to timeliness, 83% of respondents rated timeliness as excellent or good, and this is consistent with what we heard in 2021. Related to correctly answering or providing information the first time, 82% of respondents replied excellent or good. Now that's slightly down from 2021 where that was 83%. Helpfulness of staff, 85% rated excellent or good, and that is consistent with what we heard in 2021. And then if you go to the next slide, you'll see the next 3 parts of that question. So for knowledge and expertise, 83% of respondents rated excellent or good. Now that is also slightly down from 85% in 2021. On availability of information, we have 81% of respondents rating it at excellent or good, and that is the same that we heard in 2021. And then lastly, there's overall service, and 83% of people rated the service as excellent or good, and that is consistent with what we heard in 2021. So any questions about that slide or the last 2 slides? Yes, Tom.
So is there any way to know whether the people who wrote fair for one question basically wrote fair for everything, and the people who, do people just basically check down, excellent, 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 and the next group does good, 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 and the next group does fair, 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 and the next one does poor, 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 poor? Or is there it's just an interesting way of the numbers are so consistent across 6 different parameters. It's just it just seems odd to me.
Yeah. So Tom, I do have my colleague Adrienne Kafka on the line as well. She was helping put together the data and everything. I don't think we did not look at the questions to look, I think, just to see did like people consistently check excellent or consistently check good. We certainly could go back and take a look at that. But Adrienne, do you have anything to add related to Tom's question?
Yeah, we certainly could go do more in-depth analyses along the lines of where people consistently saying the same thing.
I'm not trying to suggest more work. Don't get me wrong. It's just it was just so kind of odd that the bars didn't move back and forth depending upon what the question was.
Mm-hmm. Yeah, there is some movement, but it's pretty slight. Yeah.
I'm not calling for more work. Don't get me wrong.
Well, Tom, you raise an interesting question, though. One that
look at it maybe next time.
I want to look at it. Yeah. Yes. No, that's a good point. We definitely will. Thank you for that suggestion. All right. So the next question was, how satisfied are you with my OEB? And so this is the benefit enrollment system that if you put in, oebenroll.com, so where you go in and actually like make enrollment decisions. So how satisfied are you with that site? And for that site, 92% of people rated the site as very satisfied or satisfied. And just a note here, the responses changed to very satisfied, satisfied, dissatisfied, and very dissatisfied, and we use the same colors here that we had used on the previous question. So 92% answered very satisfied or satisfied, and these results are consistent with what we heard in 2021. All right, so if you have questions, let me know. Otherwise, I'll keep going. All right, so on the question about thinking about OEB's website, so now this is the education site, oebinfo.com, where you would find information about all the benefits, access the benefits guide, et cetera. How satisfied are you with the organization of that site? And in 2022, 86% of people are satisfied or very satisfied with that site. That is the same percentage that we heard in 2021, although there was a slight increase in satisfaction you can see the numbers are slightly different. So slight increase in the very satisfied group compared to the satisfied group from 2021 to 2022. All right, on the next slide, so thinking about that same website, so oebinfo.com, how satisfied are you with the content of that site? And in 2022, 91% of people were very satisfied or satisfied. That is a slight decrease from 2021 where that was 92%, but still I think that's a very positive result or percentage of people responding. All right, so on the next slide, we have another multi-part question here. So thinking about the communications that OEB has offered in the past year, how satisfied are you with the methods used, the frequency, the content, and the effectiveness? So again, the scale here is very satisfied to very dissatisfied. Colors are the same. Actually, are colors the same? No, colors are a little bit different. I apologize. Blue is very satisfied. Green is satisfied. The maroon or red is dissatisfied. And then the yellow is very dissatisfied. So if you look at these, again, you can see the 2002 compared to 2021. So for methods used, 94% of respondents said that they were satisfied or very satisfied. That is slightly down 1% from 2021. Frequency of communications, again, 92% rated it very satisfied or satisfied, which is down 1% from what we heard in 2021. On content, 94% of people said that they're very satisfied or satisfied, and that is slightly up from what we heard in 2021. And then for effectiveness, 92% of respondents rated very satisfied or satisfied, which is down 1% from what we heard in 2021. So any questions? I'll keep going. All right. So then I know this is going to be of interest when we ask what methods of communication do you prefer? And you can see that the vast majority of respondents indicated that email is their preferred communication method from OEB. We did also ask about webinars, videos, the website, text messages, and mailing information to home. You can see that website came in second at 31%, and then information mailed to home is 28%. But again, vast majority chose emails. Now, this is a new question that we asked in 2022, so we don't have any year-over-year comparison, but we do plan to ask this question going forward, and we'll be able to provide that year-over-year comparison going forward. All right. So now we're getting into the member comments. So if we go to the next page, we've taken the member comments. We've been through all of those comments and coded them. So coded them into like categories or topics. And so I have two slides to share here. One is the top 3 likes that we heard from people. And then we also have the top areas for improvement. And we'll see that on the next slide. But in terms of the top 3 likes, we are showing 5 different categories here: member services, coverage and benefits, information, enrollments, and premium and costs. And then the numbers that you see there in parentheses are the number of people who wrote in a comment related to this topic. So for member services, there's good or great service, keep up the good work. There was 116 people who wrote in with that kind of comment. For helpful, it was 37 people. And then that member services is knowledgeable and can answer questions. There were 23 people. And I would also like to point out that most people take the time to write in comments that are negative. So I thought it was a really nice number here showing positive comments. And certainly, taking the time to let people know that, the service was great or good and keep up the good work, I think is a nice to hear. So on coverage and benefits, there was the top comment was that's good coverage. I have no complaints. That they appreciate the number of options. There were 6 people who said that. And then the number 3 was that Weight Watchers is great. So 5 people indicated that. On information, the top comment was about receiving helpful information and communication from OEB. 30 people indicated that. The website had improved. 9 people wrote that, and that there was a good benefits webinar and that appreciated that resource. 2 people wrote in about that. For enrollment, the comments were about it was easy to enroll. 6 people said that it was a smooth process. 1 person put that, and that it was helpful, and that the webinar was like a helpful and good preparation for open enrollment. And then last but not least, there was 1 comment about premiums and costs and that they were affordable premiums. So definitely included that. All right, and then if we go to the next slide, this is the top areas for improvement. And again, same categories here that you saw on the previous slide. And then also here in the parentheses is the number of people who made those, who wrote in with that comment. So on member services, the top areas for improvement were that they were given inaccurate or inconsistent information. 37 people indicated that there was a lack of follow-up or that OEB was slow to respond. 25 people wrote in that, and that they were not knowledgeable or that they were unable to answer questions, and 12 people answered that. And just, people have written in the comments and explained their situation, but just want to keep in mind that when asked in the survey about the service, just a reminder that, the average of, 82.8% of people said that they were satisfied or very satisfied with service. So just want to keep that number in mind as you look at the comments. On information, the top areas for improvement were that they had questions about their coverage and that they wanted more benefits information. 79 people indicated that. That the website is hard to use and to navigate. 79 people on the top comment, 75 on the second comment. And then that they received too much email or too much messaging from OEB. 70 people indicated that. I just think that's interesting given that there was such a large percent of people who had indicated that email was their preferred method of communication. Also, 86% of people had answered the question that they were satisfied or very satisfied with the communication. So keep those numbers in mind. On coverage and benefits, we included a few more things here than the top 3 because wanted to make sure you saw the top comments that we received. The first one was about level of benefits have decreased or that they want more coverage. 102 people wrote in with that. That they want more choice of insurance companies. 63 people wrote in about that. And then there were questions about prescription drugs, questions about dental coverage. And then, so 45 people wrote in about the prescription drugs, 42 people wrote in about dental coverage. And then there were 37 comments about having issues finding in-network providers. And then lastly, there were 23 comments about mental health coverage, having questions or comments or problems related to the EAP. And I just want to note that the top 3 responses here in terms of the level of benefits being decreased, wanting more choice of insurance companies, and then prescription drug questions, that those are the same top 3 areas of improvement that we heard in the 2021 survey as well. And then if we move to enrollment, the top comment was that they want a passive enrollment and want coverage to be able to roll over year over year. There are 62 people who wrote in about that. And I'll just note that that was also this top comment that we received in the last 2 surveys, and also is the same top comment that we receive on the PEB survey when we do that. So the second comment there around enrollment is that the enrollment process or the website is confusing. 53 people wrote in about that. And then the third thing is that people are looking for a summary of their current coverage. They want that to be available during the open enrollment process. And 14 people indicated that. And last but not least, premiums and costs. So first, the top comment about with areas of improvement was that the premiums were too high and that we needed to reduce premium costs. 114 people wrote in about that. That out-of-pocket expenses are too high. That was 41 comments. The deductible is too high, or deductibles are too high. 37 people wrote in with that. Costs are rising too high or too fast. 31 people wrote in about that. And that copays are too high. And just want to point out that that first comment about the premiums being too high was the same top comment, if you will, last year as well. Although the number was reduced, there are about 225 people who wrote in about it in 2021, and there are 114 comments here. So that is the customer service survey in a nutshell. Like I said, there are 2 appendix. One shows the demographics and shows those in more detail if you want to take a look at them. And then the second appendix is all of the member comments coded. So you can see how all of those questions, what those topics were, and see the numbers around that. So any questions about the survey? Michelle?
Hi, thanks for this. I do have a question as a relatively new member of this board. I'm just curious why we're not asking them about member satisfaction with things like deductibles and the quality of the coverage. Is that something that we do in another survey, or is this more about communication and OEB specifically?
Yeah, so, and Jackie, please feel free to jump in. But I know this survey was specifically targeted to OEB and OEB customer service. We are planning a second survey, which will actually come out later this month. And that survey will be around the vendor partners and asking around medical, dental, vision, EAP, just so asking feedback about that. Right now, I don't think we're going into specifically around I think we touch on costs at a high level, but we don't go into like out-of-pocket maximum, copay,
Right.
deductible, like those specific elements. But thank you for asking that question, because I did mean to say that we'd be doing the second survey and it would be coming out. Originally in the customer service survey, there were some vendor partner questions, but it was decided to break that out into 2 surveys so that we could go into more detail on the vendor partner survey. So again, that is coming out later this month. And then once we run that survey and can run the reports, we love to share the results with the board as well on that.
Awesome, thank you.
Yeah.
I don't know if it's too late for this second survey, but I do think it's important to ask members or kind of have a way of stratifying members who use their benefits a lot and members who are like relatively healthy and might just kind of use the preventive benefits. I'm really interested to learn about members with chronic conditions or who have had some kind of health issue, how satisfied they are with the coverage.
Okay, that's good. Yeah, we'll take that back and talk more with like Jackie and Cindy about that. Thank you for that suggestion. Yeah. And Jackie,
Michelle,
did you have anything to add?
Great.
Oh, sorry.
I was going to say, Michelle, great question and comment.
Yeah, this is Jackie. The only thing that I would throw in there is just to emphasize that we used to incorporate both of those questions together, like asking about the your satisfaction with the plans and deductibles and such, as well as customer service. And the survey got so long that we had to break them apart. So the fact that people are commenting on those things at the very end, that's really just, we had this open-ended box at the end that said, is there anything you want the board to know? So that's why those comments are getting kind of straggled into this survey, whereas we're actually going to specifically ask about that in the other survey.
And there will also be an open-ended question in that survey asking the same thing, but this one is, focused on the vendor partners and coverage. All right, anything? I don't think there's any other hands up, but please let me know if I'm missing anybody.
I would like to throw out there just a thank you to Mercer for doing all of that work, because we used to do it ourselves. And I don't think members really recognize that a live person really reads all of those comments, and it takes a lot of time, and especially not just to read it and process it mentally, but then to put them into categories, because we didn't prompt them with, do you have any comments about this category or that category? It was completely open-ended and just one box for everything. So the fact that Mercer went through and read them all, figured out a way to group them so that it could be summarized and organized, is just an amazing amount of work. So thank you.
Happy to do it.
Okay. Well, thank you, Erin and Jackie. I appreciate the work and the presentation.
Yep, thank you.
Okay, so we're moving on to the Health Equity Work Group update, and that's Christy.
Robert, we kind of got out of order just a little bit earlier, and Christy gave her update already, so we could just move on to the next item.
I get that now. Okay, thank you for that.
Yeah.
Let's move on to the OEBB stakeholder group update then.
Hi. I'm Georgianne Helmuth. I'm the Senior Account Executive with OEBB and PEB, and want to give a little update today about the advisory group and the work that they are currently doing on behalf of providing feedback to OEBB and also helping the districts understand and transfer information from the board out to the different entities at OEBB. So next slide, please. So to give a reminder of the advisory board, the committee was really set up to support OEBB, the K-12 and the community colleges, wanting to look at improving effectiveness and understanding of the employee benefits. Employee benefits are complicated, as we all know, and certainly the board understands that. You're faced with many decisions to be made, and then we have to get that information sent out to everybody so they understand how does this impact their lives. So the advisory committee is providing that support. They are spending a lot of time really learning about all the programs offered by OEBB and really starting to get into a deep dive and understanding how the rates work, how do the benefits work, and working on the two-way communication so that feedback coming from our covered members is coming back to the board, and the information from the board is being disseminated to the members in a way that makes sense. And through this process, there are some initiatives that are getting launched in order to help people understand things better. And that's something we're going to update on today. So go ahead, the next one, please. Just a reminder, these are the advisory committee members. These members obviously represent large constituencies of individuals that are impacted by OEBB and by the decisions this board makes. And, they are our biggest supporters and our biggest challengers to make sure that, the OEBB board and the OEBB benefits, that they are doing what they're supposed to do. So you can see all of the big groups are represented on this board.
Georgianne, can I ask a couple of questions on this?
Yes.
So y'all meet monthly, is that right?
Yes, it's a couple times through the year. Go right now through open enrollment, we're meeting monthly, and then we kind of take a break through the summer and come back in the fall.
And I'm looking at the list. My other question is, are there any of the listed groups that aren't participating as much as they should?
At this time, I would say no. Everybody is very actively involved right now. I've been working with this group for when I've been here for about 18 months and have been working with them that whole time. And I've had the opportunity to get to know, I think, every one of these pretty well. We've had an opportunity to meet with them on one-offs. And also I'm getting a pretty good feeling about where their members are coming from.
Great, thanks.
And if I could just add, Robert and Georgianne, I think from the question earlier, I mean, I think this is a great group to run questions like, how do they feel about deductibles versus copays versus ER copays? I mean, things like that, you know, would be, I guess, more painful than others, or just questions like that. I mean, it's been a really great group that can go back to their constituents and get us information really pretty quickly too, when you say Georgianne.
Absolutely. They're very responsive and glad to ask questions of members and get information back to us. They've been I think they're a good partner as we go through this. Okay, next slide. This is just kind of a update on a current project that we're working on. We're calling it the Deep Dive Project. This is something that is not going to come as any kind of surprise to anybody at this meeting today. This is what we've been talking about through this whole meeting. It's around the renewal and around the cost of the OEB programs. So as we know, Senate Bill 1067, you have standard 3.4. We all understand that's an aggregate. It includes the medical, dental, and vision all put together. Every year OEB's met that. The actual school districts and a lot of the entities, what they're hearing from their legislators and what they're hearing is, my cost should not go up more than 3.4%. And so they're budgeting out at 3.4%. And then they go through enrollment and their district ends up with a 4 or a 5 or a 6, depending on the enrollment mixture. So we're trying to help explain this in greater detail so we can take these board decisions. We hit 3.4, but what does that really mean to the district on a district by district level? And you can go to the next slide, Rose. Thanks. A quick example. Here's a couple of examples that we kind of just to give an idea. You have one district, they offer all of the plans. They're in the Kaiser, so they offer all the MODA, all the Kaiser. In the first year, the district has they have their cap, and the amount that they can provide for contribution will cover Plan 3 with dental and vision. So the employee has no out-of-pocket expense if they take Plan 3 with dental and vision. The next year, the district increases their contribution, and now their contribution is enough that now they can cover everybody on Plan 1 with dental and vision. Well, when you change that contribution, you have people are going to jump from Plan 3 to Plan 1. The premium is more. Their cost increase will be greater than 3.4%. And just some examples here of how that can impact these districts and coming into what is that enrollment mix. And I know that Kirsten was talking about this earlier when we went through the kind of the breakdown that 77% of the districts are getting 3.4% or less, with that big caveat, based on their enrollment in December 2022. If they enroll exactly the same in the same plans as they're in right now, or they were in December 22, they should come out around the 3.4. But if people are migrating to different plans, and we saw that happen last year, a lot of people migrated to Kaiser Plan 1, which is more expensive, and a lot of districts ended up having higher costs and caught off guard on that a little bit. And you can go ahead and go to the next slide. So what the advisory board is working on right now is we've identified 4 districts, 2 community colleges. There may be some additional districts and community colleges involved in this process. But reaching out to these entities, and we've chosen different areas around the state, different sizes of districts to try and get kind of a cross cut of what this population looks like that we're covering with OEB. And we're going to go to the districts and ask them for all of their contribution information. So by classified versus licensed, what are those contribution amounts? What do they go through in putting that together? What are the levers that they pull, and what are they looking at? We're going to look at them for a couple of years history, 2 to 3 years, to take a look at how they have on a entity specific level. How have they experienced that 3.4? Has it been greater or less for them by district? We want to identify as we go through this to get a feeling for what's happening with these decisions they're making. So the amount of contribution, the amount of offerings that they're having. Are they offering all of the plans? Can they offer Kaiser? Are they in or out? And we're putting together, trying to get together some best practices. We can see those districts that are having great success and really managing well to the 3.4. We want to learn, what are they doing? What are things that they can, are there any tricks of the trade out there that we can share among other districts so that everybody has a better understanding of what does the 3.4 really mean? How can they impact it? How can they not impact it? Some of this obviously is going to be, employee choice, but really trying to get into the weeds around understanding this increase, because everybody says, hey, it's 3.4. No, there's a legislative mandate that the cost can't exceed 3.4, but that doesn't mean it's going to be 3.4. So just trying to really clarify with all of our members and all of the entities to help them understand in greater detail how they can affect their renewals and those outcomes. And the last slide, questions or comments?
Georgia, one other thing that at least employers can consider is offering one plan that they pay in the entirety, and then they know what their costs are, so it's not that hard.
Exactly, and good point, Robert. What we're finding is these districts are all over the board, so really trying to help a little more, get in a little more detail with these districts and help them understand that. So if we can show them some examples of what others are doing, hopefully we can start rolling this out and start working with more and more of them on a one-on-one basis to really help them make decisions in their benefits program that will meet what they want to do with their budgets. That's an extra point. Excellent point. Anybody else?
Well, thank you, Georgianne. Very helpful. Okay. All right. I think, Glenn, I think we're up with the legislative update.
Thank you, Robert.
No. Yes, that's right.
Well, my name's Glenn Bailey. I'm the Policy Program Development Coordinator and Legislative Lead for PEB and OEB. As many of you have seen in the papers, the legislative session is halfway through. Basically, what has happened is the first chamber has reviewed all the bills and through their policy committees, and either they sent them to the floor to be voted on and then sent to the second chamber, or they sent them to House Committee on Ways and Means, and the House, or I'm sorry, the Joint Committee on Ways and Means, or one of the Rules Committees, or also for Revenue. These committees can pretty much, hold the hearings till the end, and then can send them either directly to the floor, or in cases of the rules, if it has a price tag, they send it to Ways and Means. So, we, so far, really, I just wanted to give an update on those bills that are really of high importance to PEB and OEB, as well as just a general overview of the subject areas of bills that we're also following at this time. The first one, I think I'll start with the good news. First of all, is House Bill 3140, which is the third down. This is a bill that was introduced in the House, and it basically would get rid of the 3-year RFP requirement for consultants and actuaries. This passed the House. It has gone through the Senate committee, and it's at the Senate floor right now. There is no expectation that it's not going to pass and not be signed by the governor. So that would mean that PEB and OEB no longer would have to do an RFP for a consultant mandatorily every 3 years. One of the big bills that we have been following, because it has a large impact on us, is the House Bill 2878, which is the Global Budget Pilot Bill. This was a bill that was introduced by Representative Dexter. It would require that OHA and actually PEB and OEB would be mandatory on this, would do a pilot project of global budgeting in a specific region. They also want one commercial payer to be involved, but that's voluntary. This, I won't go into the details. There's a number of concerns about the impact on providers, the network, on choice, on costs, because its final version did require an above the cost growth target premium, which would lead to extra costs for us, as well as a specific costs around stop loss insurance, excuse me. The cost for this bill would be $14 million in the first biennium, 10 million, excuse me, 14 million and 10 million in the second biennium, with actually large costs actually coming in for PEB and OEB when the bill would be implemented, or when the pilot would be implemented in 2028. Ali, did you want to kind of chime in on this bill? I mean, in regards to it.
Yeah, I mean, I don't really have a whole lot to share other than things really seem to be kind of on hold right now. They're waiting on the next revenue forecast to come out, which I believe is in about a week and a half. And so a lot of bills are kind of held up in Ways and Means. And I think after that, things will have a much clearer idea of what's actually going to get moved. Thanks, Glenn.
Yeah. Just to, Ali's correct. The revenue forecast won't come out till May 17th, and once that forecast comes out toward near the end of May, you'll really start to see things picking up in Ways and Means, and they tend to move very fast at Ways and Means with bills, and you will know by the end of the month whether this bill is going to move or not. The next bill is actually a PEB bill, but would allow Oregon State police officer retirees to participate in PEB with, based on the same cost sharing they would have as a as an employee. So there would be a large cost to PEB on that. The last bill is House Bill 3383. This actually changes the minimum number of board representation on the OEB board. It would add a member who is classified and working in a public school or education service district. And then it would also reduce the number of health policy representatives from 2 to 1. Now, this is for the minimum, and we're going to start looking into about, because that just says at least a minimum in our language, whether that, there would be ways to still retain our 2 representatives, but just change what the minimum structure would be. So we're going to be looking into that. Next slide, please. We still have we have 27 bills that we're still monitoring. These would be bills that would have a financial impact on PEB and OEB. We have one around infertility benefits. We have several bills around prescription drugs, limitations on PBMs. There's also a bill on upper payment limits, or at least a report on that. And then one on what's called a drug pay accumulator, which was included in the OEB renewal for the MOTA plans. There's a bill to make some modifications on the Senate Bill 551 program for part-time faculty. There's a bill, and you've probably seen it, it's been in the news, House Bill 2002, which adds benefits for gender-affirming care and a required network of gender-affirming care specialists. Some bills on behavioral health, House Bill 2002 on reproductive health rights. There's also a bill that came through on the House healthcare side, which would create what's called a health insurance mandate advisory committee. This would be a committee led by legislative staff, but include an OEB and PEB member, health insurers, providers, as well as consumers, who would, prior to the session and even during the session, would do a very extensive report on any benefit mandates that the legislators want to do, looking at cost, effectiveness, health equity, and then provide these reports to the legislators as well as during the session, so that really the idea behind this was that the legislators would kind of get a fuller picture versus what they're receiving right now, which is done on a very short time frame. There's a bill on universal health care in the state of Oregon, and then just a number of benefit bills, health aid, hearing aid coverage, sickle cell disease, just a number of others that we commonly have each year. Are there any bills or any questions that folks have? Okay, well, just to kind of wrap up, as I said, we're continuing to watch, any of the bills that are still move through the first house and then moving on to the second chamber, but also those bills that are in Ways and Means and in rules, because they will hold public hearings and work sessions in those committees, to also responding to any requests that come in from legislators and from the Legislative Fiscal Office on that.
Okay, thank you so much, Glenn, for your work and
All
your
right.
presentation.
Thank you.
Thanks, appreciate it. Okay, Rose, do we have any public comment?
No, no public comments.
Okay, well then, I think our job is done for this month. Ollie, we have one for June, right?
We do. We'll have a board meeting in June where we'll talk about new board leadership. Our fearless leader, Robert's last board meeting is chair is coming up, and we have a vice chair and JJ moving up into that role, and I'll be working to find a new vice chair from a non-management board member. So I'll be reaching out to board members this month. Look forward to the conversations.
Is it going to be virtual or in person?
In June, we'll be talking with JJ, but we'll be virtual in June and talk about retreats once we get back.
Great, thank you.
In that case, I will see everyone virtually in June, the first Tuesday in June. And I thank you for your participation today. And I think this is a culmination of a pretty good year. So I really appreciate everybody's effort.
Yep, thank you very much.
Okay.
Thank you.
This meeting's adjourned.
Thank you. See you later.
Thank you.